Hello, good evening. This is day 2 at ESICON 2018, the 48th annual conference of Endocrine Society of India. We have with us all the way from Rohtak, a senior personality in Endocrine Society of India. We have Dr. Rajesh Rajput with us. Welcome, sir, on board. This is ESI TV, an academic initiative where we are sharing current news, updates, opinions from the experts and clinical development from the scientific program here at ESICON 2018. So let us get started. Let's talk about the evolution of endocrinology that you have witnessed. Also talking about your association with ESI.
Well, I have a long association with ESI. I have served as an executive member for 2 terms. I am closely associated with Progress of Endocrine Society of India, and presently in India we have number of patients increasing with various endocrine disorders. So there is a growing need to educate our doctors regarding various endocrine disorders so that they can diagnose various endocrine diseases and can give them the effective treatment. And Endocrine Society has a great role to play in it. Meetings like this, they are very informative for all the colleagues who are coming from across the India and attending these meetings. They take home important messages for treatment of various endocrine disorders, so that ultimately at the end of the day, when they go back to their cities and start treating such patients, patients are benefited.
Sure, and talking about ESICON 2018, new initiatives have been taken care of.
Well, I think there are a number of new initiatives which has been taken up by our organizing secretary of this ESICON, Dr. Abhesahu. This, the platform on which we are now speaking, actually is a new initiative.
Yes.
This has been taken up for the first time. Apart from that, there are many such new things which has been taken up. So these are welcome additions. One of the new things which has happened for the first time in Endocrine Society, and which actually all of our colleagues, senior colleagues, co-colleagues and junior colleagues are appreciating, organizing alumni meet for all the places where currently DM in endocrinology is done. So it provides a platform where all our friends come together, meet together, sit together, share their old memories, and then we also come to know what they are doing presently. So wonderful new initiatives, and I hope all these new initiatives and many more such new things will happen in future ESIs.
Correct me if I'm wrong, sir. You're talking about the alumni meet yesterday evening, the gala dinner time.
Yes.
Yes, along with that, we've had EPL yesterday, a grand debate session.
Yeah, that's again a new initiative. Similar initiative has been started virtually now in every specialty. This has been taken, a clue has been taken from IPL. What is EPL, which is an endocrine premier league? We give an endocrine topic where 2 teams given a chance to speak over it, and the audience has to vote whether they want to give 4 points, 6 points, which is equivalent to 6, 4 is equivalent, points are equivalent to 4. So the audience are involved, 2 teams are involved, and this has been appreciated across the colleagues, whether they are participating on as a team, as an EPL team, or whether they are participating in our audience. So this is a new welcome addition.
Sure. On this note, we would also like to congratulate the East Zone who came out winners yesterday for EPL, and today the Panchayat session is on. The quiz is going to happen. Also along with it, ladies and gentlemen, we are also talking about sports and endocrinology. 5K marathon awaits you Sunday morning, so stay tuned with us. Now coming on to the topics that you've covered as of today in the symposium. The first being diabetes and heart-related issues. So could you please have a quick overview about
I have
the symposium?
spoken about diabetes and heart failure in my first lecture. Management, a new paradigm shift. Most of us think that these are 2 distinct diseases, but actually each begets another. Diabetes begets heart failure, and heart failure begets diabetes. They share many pathophysiological defects. Way back in 2002, we have done our own research where we have shown that at least 60% of the diabetic patients, without having any evidence of inducible ischemia, have diastolic dysfunction. Now the newer studies which is published in 2014 onwards have shown that virtually 1 in every 5 diabetic patients have undiagnosed heart failure. What is important when we are seeing a patient of diabetes and heart failure? There are 2 important messages to be remembered. One, we should use glucose lowering agent which will not adversely affect your heart failure status. Similarly, when we are using drugs for treatment of heart failure, they should not worsen your glycemic status. So I have discussed in my lecture a new drug, ARNI, angiotensin receptor neprilysin inhibitor. This is a new drug which has been available for treatment of heart failure. It has received class 1 approval from US FDA based on the robust data which has come out of Paradigm heart failure trial. What this trial sub-analysis has also shown, that diabetic population which is having heart failure, when prescribed this drug, has a better control in glucose control as compared to placebo arm. At the same time, significant less number of patients required up titration of oral anti-diabetic drug or initiation of insulin if their glucose are not initially controlled. So the drug, apart from controlling heart failure, providing mortality and morbidity benefit, which is significant, as well it also control your glucose. So we have a new drug for treatment of heart failure and diabetes. It can be used even without diabetes, but if we are seeing a patient of diabetes and heart failure, where in diabetes armamentarium we have now SGLT2 inhibitor, for heart failure we have ARNI. So in future probably we will see where we have some new data where SGLT2 inhibitor and ARNI can be combined in patients of diabetes and heart failure.
Sure, this is something, the kind of development or the current advance that we do not want to miss. Let's head and turn towards topic number 2, that is endovigilance in hypertension, and a quick overview again for this.
Yeah, today's evening I deliberated on a topic, endovigilance in hypertension. As the name suggests, how an endocrinologist should be vigilant about secondary causes of hypertension. Now it's not uncommon. When a person comes to you with hypertension, most of the time we tend to prescribe a drug and we tend to forget. At least 15% of the cases of hypertension has a secondary cause. And in these secondary causes, the two big important causes responsible for secondary hypertension are renal diseases and endocrine diseases. And at least there are 16 different endocrine disorders which are responsible for causing hypertension. If you are seeing a hypertension in young age, children's, if you are seeing hypertension in a young adult less than 40 years of age, if there is hypertension with hypokalemia, if there is a fluctuating hypertension, if patient has a hypertension with family history of cerebrovascular accident in any relative at a young age, these are all the things which actually should give us to a pointer that this patient might be having an secondary cause and especially an endocrine cause for hypertension. Now it is very important to understand that why we should not miss, because if we have picked up an endocrine disease right at time, we have to treat primarily an endocrine disorder, and hypertension will have a permanent remission. Patient may be off the drug, but unfortunately because of low index of suspicion, our general practitioner colleagues most of the time do not have a suspicion for disease, and patient goes on carrying this disease and will suffer from unnecessary morbidity and mortality. In my lecture, showing you the data, showing the evidences, showing the practical clues so that they can take home some important messages, I have also discussed 3 cases which actually we have diagnosed, which are having hypertension from last at least 3 to 5 years, but where an endocrine cause is not thought of, not picked up. When they were referred to us, we have diagnosed those diseases, and all these diseases are published in reputed international journals like BMJ case reports. So at the end of the lecture, the audience were taught about the importance of secondary causes of hypertension, when to suspect endocrine hypertension, how to investigate endocrine hypertension, what should be their index of suspicion, and how to treat accordingly.
Sure. One last message to our budding endocrinologists with the area of expertise. Any quick tips for them?
I think the one message which I like to give, do a good ethical clinical practice, keep eyes open for various endocrine disorders in a patient who is coming even with a non-endocrine illness. By doing so, we can pick up the disease at early age, early time, and we can provide proper treatment to our patients.
Sure. Thank you so much, Dr. Rajput, for joining in with us here and giving such wonderful overviews about both the topics. And thank you once again for joining in with us.
Thank you very much.
Thank you.